This next lecture content will be on high-risk delivery. So why have we seen such an increase in severe morbidities in the United States? Well, we see some new comorbidities as well as pre-existing health conditions that are compiling onto this, as well as some other things. First of all, advanced maternal age, which is defined as a mother who is 35 or older when she's pregnant. And American mothers are now older than ever when they're having their first or their pregnancies. They go well into their 30s, whereas before they used to have children at a younger age. And now with careers and two-income families, you're going to see that more moms wait or delay getting pregnant, and then you have more moms falling into this advanced maternal age category, which puts them at a higher risk factor for some genetic problems as well as some pregnancy complications. Another reason is inadequate health insurance or care, specifically those in low-income or rural areas. And then another one is increase in women's weight. So maternal obesity is one of the leading causes for infertility, as well as pregnancy, labor, and delivery complications. And we all know that Americans have had struggles with obesity, and we are one of the countries that have the highest obesity rate in the world. Others can be pre-existing conditions or complications that if they had this before they were pregnant, it only intensifies complications or intensifies these diseases with the stress of the pregnancy. That would be asthma, hypertension, diabetes, obesity, and substance abuse. So in 2016, Ohio was one of the 5 states with those highest rates of death due to drug overdose, 39.1 per 100,000 people. And again, specifically targeting those in those rural, low-income populations who are at greater risk. When we look at race, that can have significant impact on the severity or complications in pregnancy. Black women have increased rates over white and Hispanic women, and they have increased rates of chronic disease and prolonged stress. So when those women get pregnant, they can add to pregnancy complications as well. And then lastly, delay or denial. Women tend to ignore signs and symptoms of something being wrong or serious, and they might even delay or avoid the medical treatment they need. So if treatment is sought, doctors and nurses often fail to recognize the distress signals because childbirth is natural and most women don't have problems or complications. So when one does arise, either the patient themselves does not recognize it or kind of brushes it under the rug, or doctors just kind of don't recognize it immediately, doctors or nurses, and figure that it's likely not going to be something, when oftentimes it is. So in labor and delivery, we're talking about complications, and we're talking about what makes this high risk as opposed to a normal labor and delivery process. So earlier we talked about those 5 P's of labor. So when we're talking about high risk delivery, we're talking about any kind of abnormal or changes in those 5 P's. So first we're going to talk about abnormal or difficult labor. So we're talking that there are problems with one of those P's, and dystocia means difficulty. So one of the problems with the P, or the power, is that it's either not enough or too much. So hypertonic labor is when uterine hyperstimulation occurs and a series of contractions that can last longer than 2 minutes, or they come as frequently as 5 or more in a 10-minute period. So either the contraction lasts longer than it should, longer than that minute to 2 minutes, and they come more like one on top of the other, so there's no resting tone interval between contractions, which we already know helps the baby get that fresh oxygenated blood back to them, because already it's cut off. Those spiral arteries are compressed during the contraction. So we know that they rely on that resting interval to get that blood flow back. So obviously this can cause a potential complication of labor with both mom and causing the uterus to hyperstimulate, as well as baby and fetal well-being and oxygenation. Another problem can be hypotonic, where the contractions are not strong enough. So uterine contractions are inadequate in either their frequency or their intensity or duration, or maybe all 3. And during the active phase of labor, which causes them to inadequately dilate, efface, or for the fetus to be able to descend into the birth canal. That's often what we call arrest of labor, arrest of descent. Those are terms we use when a mother has a hypotonic labor pattern and she's either stopped or is going too slow in the labor process, and then eventually that oftentimes turns into a cesarean section delivery. So contractions in the hypertonic are frequent, but they're ineffective in promoting dilatation and effacement. So although she's having them long and they're more frequent, they're not effective in this manner. And the uterus remains tense between those contractions, which can lead to that reduced placental fetal circulation and the fetal distress. So the treatment in these cases is we can administer either pain medications and or a tocolytic. The most common we use is terbutaline, or what's called breathine. It's a sub-Q injection which relaxes smooth muscle of the uterus, and almost an immediate effect. We notice right after the sub-Q shot that the contractions should start to space within a minute or so. It works very quickly. It can also, the side effect can be tachycardia on mom and baby as well, so we have to watch for that. So in the hypotonic, we know that it's because they're inadequate, and then if contractions are inadequate, it cannot lead to proper cervical changes of the progression of labor. And to treat this, we can either hydrate her. Sometimes it has to do with dehydration states. We can perform an amniotomy where we break the bag of water. We can augment her contractions with oxytocin or synthetic oxytocin, which is Pitocin, and we can try to get those contractions to get closer together, or we can get them stronger or longer. And then a C-section, if any of our treatments don't work and we cannot get her into a good labor pattern, then she will end up delivering via C-section. Another problem that can occur is precipitous labor. This is where rapid birth occurs within 3 hours from the onset of labor. It also can be an abrupt onset of contractions. Factors that can be associated with this is the abruptio placenta can cause a woman to have this precipitous labor pattern, fetal meconium, maternal cocaine use, and this all can result in the postpartum hemorrhage in mom and low Apgar scores in the newborn. Another complication can be precipitous birth. So this could occur after any length of labor. So whereas the precipitous labor is the quickness of the labor, this is the quickness of the birth. So this can occur even if mom has labored a long time. The birth itself can happen quite rapidly. A physician and midwife can often miss the delivery because of how quick it happens. The nurse may also need to assist mom with the delivery if he or she can't get the proper personnel there. It can happen before a patient reaches the hospital. So those are the births you hear about that happen at home or in an ambulance or an emergency department. And due to this precipitous birth, infants can suffer trauma. This can result in intracranial hemorrhaging, hypoxia, respiratory distress. Again, they lack that thoracic squeeze that helps push all those fluids out because of the rapid delivery. It can also increase the amount of bruising they have. And remember, when we think bruising, we always think red blood cell breakdown and we think jaundice. And the mother can suffer some trauma as well. She can have perineal injuries with pretty severe tears. She can have pubic bone injuries or tailbone where women have broken their pubic bone or their tailbone due to this. And then psychologically, it's just a very traumatic situation to feel that birth is coming so quickly and uncontrollably, especially if the right medical personnel are not around. So problems with the passenger and the passageway. So when we talk about the passenger, remember we're talking about the fetus. So problems that make it a high-risk delivery could be if the baby is macrosomic, so fetal size could be a problem. Fetal position and presentation can be a problem if the baby has a malpresentation, if they have one of those compound presentations, or they're in a transverse lie, or they're in a breech presentation. This is any kind of malpresentation that can cause the delivery itself to be difficult or high risk. And then you can have problems with the pelvis or the passageway due to the shape or the size of the pelvis or the soft tissues. And then you could also have an abnormal duration of the labor as well. So there could be problems with inadequate expulsive forces. So we know that this occurs in the second stage of labor when the woman is not able to push or bear down. So there are times where a woman is laboring, she gets to 10 centimeters, complete dilatation, and the doctor or nurse instructs her to start pushing, and for whatever reason, she cannot adequately push the fetus out. It can be that she is just exhausted, especially if she's been in labor for hours or days. She may not feel the urge to push. If a woman gets an epidural, it's not meant to numb all the nerves down by the perineum, but it can. So some women don't have a feel where to push or how to push because everything is so numb. And in those cases, we can always turn the epidural off or down to help her get some of that feeling back. There could be problems with fetal dystocia, which means that there's an excessive fetal size, like the macrosomia or the malpresentation, which is causing problems with mom pushing the baby out. Or there can be the pelvic dystocia, where she has an abnormal pelvic shape, making it difficult for the baby to navigate around those bony prominences of her pelvis. Treatment for the inadequate expulsive forces will be having the woman sit upright, or what we call laboring down. Oftentimes the contractions pushing on the fetus and the natural descent into the pelvis can be aided or hurried if you have a woman sitting in an upright position. We can augment her again with the oxytocin or the Pitocin, the synthetic oxytocin or Pitocin that we give to help the contractions get stronger and kind of aid in pushing that baby down into the birth canal. Or we can use assistive devices such as forceps or a vacuum, or the patient can just get a cesarean section if none of those can work. So when we use a forceps for delivery, this is what a forceps looks like. They're curved blades that are used to gently guide or pull the fetal head out of the vagina. Mom still has to push, even with the forceps being used. They're just help to assist. They're not meant to pull. They're just meant to gently guide. And these have to be used properly. There's a variety of forceps that a physician can use, and that's usually physician preference. And it also has to be that the head has to be low enough in that pelvic outlet to allow those forceps to come in and for us to safely use those in the infant. And so these are the different types of forceps. Elliott, Simpson, Keelan, Wrigley, Piper, they're all different types of forceps. Again, it could be different physician preference or how big the baby is or how the baby is in that pelvis. So we use these to rotate the fetal head as well as to use traction or gentle guidance or pulling. And it's a physician preference again. And we have to consider the outlet and how far the baby is in the outlet and which forceps the doctor or practitioner chooses to use. The risks of using the forceps to the infant can be small facial injuries caused by the pressure of the forceps, temporary facial muscle weakness or facial palsies, a skull fracture, bleeding in the skull, or seizures. Risks to the mother can be pain in her perineum after the delivery because we're putting an additional instrument by the perineum, tears or wounds in the lower genital tract, injuries to the bladder or the urethra during this, problems urinating or emptying the bladder afterwards because of that, short-term incontinence or loss of bladder control. There can be anemia due to blood loss during the delivery, especially if there's more tears associated with it. A uterine rupture or a tear in the wall of the uterus, extremely rare but can happen with the insertion of the forceps if not done correctly. And this can cause the baby or the placenta to be pushed into the mother's abdomen as well. And weakness of the muscles and the ligaments that support those pelvic organs, and this can result in pelvic organ prolapse. If a physician chooses to use a vacuum instead of a forceps, this is a suction cup device which provides gentle suction to help deliver the head. It's applied over the posterior fontanelle. It's then the pressure is pumped up by a pump gauge that either the physician themselves controls or the nurse can. And with that suction on the baby's head, again, same thing. Mom pushes. They use this to gently pull and guide the baby out as well. And then different things to consider with this is the baby's head low enough to place this on. Also, we have to consider the amount of times that we are pumping this up and pulling that out. There's a rule that there's a pop-off mechanism on these vacuums that if it exceeds too much pressure, either from the physician or the nurse pumping it up or from the pulling, it will automatically release the pressure and pop off. If the physician is pulling and it pops off more than 3 times, or 3 times I should say, then we know that it's requiring too much pulling and too much suction to use this to get the baby out. So the physician at that point is supposed to stop using the vacuum and then move to a cesarean delivery. So there are different types of vacuums. The first one is the Kiwi, which was pictured in the picture from before. And then the other one is the Mighty Vac. They do similar things. They're placed in the same area of the fetal head. It's just a different method, and again, a physician preference on which vacuum they choose to use. Trauma can be associated to the infant and the mother if you use a vacuum. There's risk factors to this as well. To the mom, it could be a laceration or a hematoma that's formed, again, down by the perineum. For the baby, it can cause an intracranial hemorrhage. It can cause something called chignon, which is circular edema on the infant's scalp, which is what you see right here in this picture. And it could also cause lacerations. And then again, just bringing up how the forceps can cause facial and scalp lacerations, abrasions, bruising, and facial nerve injury to the infant. We may have to induce mom for whatever reason. Either her body doesn't go into labor on its own, she's post her delivery date, or she's post-term, or she may have a health complication, or the baby may have some issues in utero that we require us to deliver this baby before her body was ready to go into labor. So this is artificial or purposeful stimulation of uterine contractions before the onset of spontaneous birth. So the indications why we would induce a mom could be that she's post-term pregnancy, she has a pre-existing pregnancy complication like pregnancy-induced hypertension or PIH, preeclampsia, eclampsia, she has a premature rupture of membranes, chorioamnionitis infection, there's fetal stress noted, a fetal demise that has occurred in utero, or any kind of maternal condition like diabetes or PUPS. So I always get this question inevitably, what is PUPS? So I do like to put this slide up for those. PUPS stands for Puertoritic Urticarial Papules and Plaques of Pregnancy. So it's a mouthful. So this is an eczema-like rash which causes tiny itchy red bumps that get bigger and form large patches that can spread down the woman's legs and up through the chest. And it's very uncomfortable and very itchy. It occurs in about 1 to every 130 to 300 pregnancies. So it's not terribly uncommon that they develop this rash, and there's different theories why this happens. So one of the theories is that it has to do with the maternal liver and kidney overload, the work that the liver and the kidneys of the mom needs to do to get rid of baby's waste products, and that could be causing this. Another theory is that it just happens to do with the abdominal stretching and the inflammation process that happens when the abdomen skin is stretching due to the pregnancy. And then another theory would be that fetal cells migrate to the mother and cause this rash. So whereas they're not 100% sure what causes it, they know what will cure it, which is delivery. So once a mom is no longer pregnant, this rash goes away. So if a woman has this rash and it's getting to the point where it's incredibly uncomfortable or difficult to live with, they will consider delivering her early because of it. And this is just an example of what it looks like. This is what a PUP rash looks like on a mom. Okay, so another reason or another complication is post-term pregnancy. This is when a pregnancy lasts greater than 42 weeks gestation. Keep in mind it's post-term, not post-dates. Remember, the due date is 40 weeks, but she's still term up to 42 weeks. So anything after 42 weeks is considered post-term. And with post-term pregnancy, there is a risk that the baby can get bigger and bigger, right? Because it has just more and more time for the infant to grow. It can cause shoulder dystocia, which we're going to talk about here in a moment. It can cause decrease in amniotic fluid. Once the pregnancy reaches about 40 weeks, amniotic fluid production decreases. So you might notice less and less amniotic fluid around the baby, or less being produced at this time. And the placenta will also begin to degrade at about 40 weeks. So anything after 40 weeks, that placenta does not function as effectively as it had before. So in labor inductions, we would say about 1 in 5 women have their labor induced. So it's not terribly uncommon. In fact, it's very, very common to have your labor induced. From 1990 to 2006, that rate doubled, according to the American Congress of Obstetricians and Gynecologists. And the induction increased the women's risk for a bunch of things when we induce them. We increase the risk of having a prolonged labor, a vaginally assisted delivery, which is the vacuum or the forceps, a cesarean section, fetal distress, maternal exhaustion, labor complications, as well as postpartum complications, like postpartum hemorrhage due to the fact that the uterus has been contracting for such a long period of time. We call that taxing the uterus. And then eventually that uterus will kind of wear out from the continual contractions being produced by the Pitocin, sometimes, like I said, lasting hours to days. And when you have a uterus that's taxed, it can have that uterine atony, which can lead to those postpartum hemorrhage and bleeding complications. So we talked earlier in the very beginning in that antepartum slide about the Bishop score. So when we're doing a Bishop score to assess a woman's likelihood of having a successful induction or delivery, we use this Bishop score. They must have a score that's 6 or higher. And if it's lower than 6, we have to consider using a cervical ripening agent first before we use the Pitocin. So we're really assessing the readiness of the cervix for the induction. Different induction techniques to induce someone can be an amniotomy, which is breaking the water, having the mom do a lot of walking, instructing nipple stimulation, which if the mother does this, she can cause the release of natural oxytocin, and this will then bring on contractions. A physician could do something called stripping the membranes, which he kind of separates the membranes around the cervix. That releases prostaglandins, which we know prostaglandins is one of the theories of what puts someone into labor. So that's another way to induce. We can use uterine stimulants, so drugs that are referred to as oxytocic drugs, which stimulate the uterine contractions. And that would be Pitocin, which is the most common one we use, or Cytotec. This could also be used to prevent and treat uterine bleeding after birth. So just as the Pitocin and Cytotec contract the uterus to get you to go into labor and to deliver, it will also contract the uterus afterwards to prevent postpartum hemorrhaging. We also can use Cytotec to complete an incomplete abortion, so to have her deliver the rest of the products of conception if she has an incomplete abortion. And we know that it can also promote milk ejection if they're breastfeeding. That's not why we use it, but it's just one of the things that could happen once it was used. So when we need to ripen the cervix, so if the cervix is not ready to take on an oxytocin like a Pitocin, we can do some cervical ripening. So one of the things we can do is a Foley bulb, where we insert a big cathetered Foley into the cervix, and then we insert 30 to 80 milliliters into the balloon, sometimes even over 100 milliliters of the balloon. That balloon that's sitting inside the cervix stretches the cervix to kind of manually dilate it, if you will, again causing the release of the prostaglandins and hopefully kicking in contractions and labor. Another cervical ripening agent is Cervidil. This is an actual prostaglandin on a small little tab that's put on the cervix to ripen or soften and to begin the effacement process, or the thinning or the shortening as we talk about. Cervidil is a medication that's on this little tab that has a string. So the physician puts this tab and places it on the cervix, and then the string is just left to hang out of the vagina so that if we do need to pull it, it's right there and we just pull that out. Another medication we can use is called laminaria. These are narrow cones that are inserted into the cervix. This will pull water into the cone and cause dilatation. We often use these in cases of those incomplete abortions, or when we're trying to induce someone who's had an incomplete abortion or a fetal demise. Another thing we can use is the Cytotec, which is called misoprostol, which can be administered either vaginally to induce them, or we can administer them orally or rectally, which is a much quicker way to do it for postpartum bleeding, miscarriages, or fetal demises. So these are just pictures of all of them. So this first one is the Cytotec. You can see it's a very tiny pill. When it's inserted both vaginally or rectally, it melts very, very quickly. This is the Cervidil. This is the medication on the string, and this is the string that's left out. This is a Foley bulb that's blown up to a hyper state of the balloon that causes stretching to the cervix, and these are laminaria rods. These also have a string on them to allow easier to take them out. Sorry about that. Let me back that up for a second. Okay, so our next page, we're going to talk about uterine stimulants. So with Pitocin or oxytocin, we do this with IV infusions to cause those uterine contractions. We use alone or in conjunction with a ripening agent or an amniotomy. So it's not uncommon that a mom starts with a Foley bulb in to help soften the cervix, as well as starting Pitocin at the same time. Or we break her water and start Pitocin. So you can do these things in conjunction, or you can use Pitocin alone. And we also use it to augment labor once labor has begun naturally. So there is a difference between induction and augmentation. Induction means that we are mechanically or chemically getting her to get into labor when her body was not doing any of it. So her uterus was not contracting. So we're starting from ground zero, if you will. Augmentation means that she has some natural labor that's begun, but for whatever reason, it's not good enough. Either that she is in that hypotonic contractive state where the contractions aren't close together enough, they're not lasting long enough, they're not strong enough. If we need to augment it to get those contractions to be more effective, we can use Pitocin for the same way. Even if she's naturally contracting, it just strengthens those contractions she's already having. And so we know Pitocin is a synthetic version of oxytocin, and it's used to induce or augment labor. We use it IV when we're augmenting, but we can use it IM in situations of post-delivery. So we can give this a shot in IM, and we also talked about how we could also do it intrauterine, because remember the uterus is a muscle itself. So during a C-section, if the uterus is exposed and mom is having some excessive bleeding, we can give Pitocin right into the uterus. So Pitocin inductions have a policy when we're managing this with an IV infusion. as far as rate changes go and maximum dosage, what the criteria is for increasing, decreasing, or discontinuing the Pitocin. And every hospital has their own policy, although they're all very, very similar based on medical guidelines. So Pitocin is supplied in many forms, but the most common is they are 10 units of Pitocin in a 500 milliliter bag of lactated ringers or normal saline, 20 units in 1,000 milliliters of LR or normal saline, and then as well as 10 units in 1,000. So we know that 1 unit of Pitocin equals 1,000 milliunits of Pitocin. So you need to know this when you're talking about a math calculation for Pitocin. So if you have an order that reads to begin Pitocin infusion at 2 milliunits a minute via an IV pump, all Pitocin has to be run on an IV pump, and whenever Pitocin is being administered, a mom has to be on continuous external fetal monitoring. So this is not the time where she can go off the monitoring and just get occasional Dopplers of the fetal heart rate. She has to be on continuous monitoring with this. So we know on hand is Pitocin 20 units. So there's 20 units in 1,000 milliliters of lactated ringers. So how do we set up our pump to run this? I will say that most smart pumps these days will allow you to just program it right in. There's a Pitocin programmed math in there, but it is good to know because there are some hospitals or some units that have the older IV pumps, and you need to know how to convert this so that you can set your pump properly. So if the order is 2 milliunits a minute, and what we have available is 20 units per 1,000 milliliters. So we take the 1,000 milliliters over the 20 units, because that's the dose we have on hand. We want to run it at 2 milliunits a minute. That's the dose we desire. We need to times it by the conversion factor, which is always 1 over 1,000. And then we times that by 60 minutes, because we need to convert the time to minutes over an hour. So the calculation would look like this. 1,000 milliliters over 20 units of Pitocin times the 2 milliunits over 1 minute, which is the order, times the conversion factor of 1 over 1,000. So now you have 1,000 times 2 times 1, which is 2,000. And then you have that over the 20 times 1 times 1,000, which is 20,000. So you take the 2,000 over the 20,000, and when you divide that, you get 0.1. Once you have that answer, you take the 0.1, you times it by the 60 minutes, because we have to convert from minutes to hours, and now we have 6 milliliters an hour. And in order to run 2 milliunits a minute, you have to set your pump for 6 milliliters an hour. So like I said, a lot of the smart pumps will do that conversion for you, and if you program in 2 milliunits, it's going to automatically feed out the 6 milliliters an hour if it knows how much Pitocin is in your bag, in this case 20 units, and if it knows how big your bag is, in this case it's 1,000. But a lot of pumps do not do that. So if they don't, you need to know how to do this math conversion so that you can program the pump correctly. So an IV of Pitocin with 10 units, so now we're changing the dosage a little bit, is in 1,000 milliliters of lactated ringers, and it's already sitting on the pump infusing at 18 milliliters an hour. So we're doing this mathematical problem kind of from the reverse side. So here's a patient with 10 units of Pitocin in their IV bag, which is 1,000 milliliters of lactated ringers, and the pump is set at infusing of 18 milliliters an hour. How many milliunits of Pitocin is the patient actually receiving? So we're going to kind of just look back at this. So we take the 10 milliunits over the 1 milliliter, we times it by the 18 milliliters over the 1 hour, we times that with the time conversion of 1 hour over 60 minutes, which gives you 180 over 60. When you divide that, your answer is 3 milliunits a minute. So we know that when this mom with 10 units of Pitocin and a bag of 1,000 milliliters has her pump set at 18 milliliters an hour, she's actually receiving 3 milliunits of Pitocin every minute. So now we're going to talk about obstetrical emergencies. First, what we're going to talk about is shoulder dystocia. This is difficulty in delivering the shoulders after the birth of the head. So this is most common when you have a macrosomic baby because their shoulders are so broad and big. This is where the shoulders, so remember the head can molt. So even on a big baby, the bones in the pelvic structure as well as mom pushing allows that head to molt, which it's supposed to do, and cone, and it can get out of those tinier spaces, especially even if it's a big head. However, the rest of the body doesn't have that molding ability, specifically the shoulders, which if you have a big baby, they're very broad. And what can happen is that the head delivers because it did that molding process, but the shoulder gets stuck oftentimes on this pubic bone, on this pubic symphysis. And again, because of usually the larger size baby, sometimes the shape of the pelvis, sometimes, mom's pushing or her pushing inadequacies can cause this as well. But it usually has to do with the size of the baby. So when this happens, the first sign of it happening is what we call the positive turtle sign. So what happens is this head gets delivered, but because the shoulders get stuck, the head snaps back, almost like a turtle snapping back into their shell, which is why it's called a turtle sign. It doesn't snap all the way back into the vagina, but it pulls back enough where you know something got stuck. So again, we talked about those risk factors are the fetal macrosomia, specifically those over 4,500 grams. Maternal diabetes, which we know can lead to a macrosomic infant, a history of shoulder dystocia, maybe due to a pelvic shape of the woman, or a prolonged second stage of labor because of inadequate pushing. So there are different medical maneuvers that can occur when you have a shoulder dystocia. So we're just going to go over a few. There's a lot of them, but I'm just going to go over probably the most common ones. First one is the McRoberts maneuver. This is when you hyperflex the mother's legs tightly to her abdomen, and this will allow her pelvis to widen, and it will flatten the spine of the lower back. So think visually of a mom in like a semi-Fowler's to like a crunch position pushing. If we need to use this McRoberts maneuver, we will flatten the bed completely. So now she's completely flat, and we take her knees and we abduct them all the way up as far as we can back by her chest. And that's going to allow that pelvis to widen, and it flattens the spine of the lower back to allow a little bit more room for the baby to go through. Another common medical maneuver is suprapubic pressure. This is often referred to as Rubin 1. But this is where you're putting pressure, the nurse usually, or an assistant in the delivery, actually puts pressure with their fist on top of the pubic bone to try to push that anterior shoulder down and away from that pubic bone. The McRoberts maneuver as well as suprapubic pressure are often used in combination. So while mom's in that McRoberts position, someone else is doing that suprapubic pressure while she's pushing to try to dislodge that anterior shoulder from that pubic symphysis, as well as widen her pelvis at the same time. And that's one of the most common and first line maneuvers that is done if a shoulder dystocia is recognized. Another maneuver is called the Woods corkscrew maneuver. This is when we turn the physician would turn the anterior shoulder to the posterior and then vice versa. So you're kind of trying to maneuver it from the fetal end. And then another maneuver is the Zavanelli maneuver, where we actually will have the physician try to push the head back up into the uterus in order for us to do a cesarean section. Now, why do we need to do this? Because we can't leave the baby's head out and take minutes to deliver the shoulders, because the baby will have compressed oxygenation and a compressed cord at this time. So it is an emergency, an obstetrical emergency. So although I'm describing these different maneuvers they're doing them very, very quickly, because you really have very limited time to get this head out. And so you're trying all these maneuvers. And again, I didn't even name half of them. There's probably 4 or 5 more maneuvers that the doctors can try. If none of those work, then they need to push this head back into the uterus and do an emergency cesarean section. Now, that's not without complications itself, but you can't leave that head out without those shoulders delivered, or the baby will die. So in those cases, you're doing these maneuvers. You're also calling or notifying a neonatal team, because we know that there's most likely going to be an obstetrical emergency, either a surgery or the baby may require resuscitation after this delivery because of the distress it puts on the baby. These 2 videos, when you get a chance, go into your PowerPoints that are posted on your Blackboard and click on these 2 YouTube videos. They're very excellent representation of the different maneuvers we do and how exactly that shoulder gets stuck and how exactly we dislodge it. So what can be the result of a shoulder dystocia? Well, there could be neonatal morbidities, including a brachial plexus injury, a clavicle fracture, a neurological injury, asphyxia due to the compression of the blood flow in that state, and then death. So this is a picture of a baby who had permanent brachial plexus injuries due to a shoulder dystocia. Another obstetrical complication is a prolapsed umbilical cord. So this is again when the cord lies between the presenting part of the fetus. It typically will occur with that artificial rupture or spontaneous rupture of membranes. And I know we talked about this a little bit with the antepartum slides, where total or part of this umbilical cord is now occluded. And there's a rapid deterioration in fetal perfusions and oxygenation due to the cord compression. And this is requiring a C-section stat. So this is just a picture of what it would look like. So the cord comes out, and then the head compresses the cord against the cervix, and that's what's compressing that oxygenation to baby. If a cord were to come out, you want to make sure that you lift the presenting part off of the umbilical cord, or have the mother go to the knee chest position. I would say the most common is that the nurse or doctor or whoever discovers the cord will go ahead and do a vaginal exam, pushing up against the fetal head to get that head off of the cord. And the nurse or physician or whoever discovers it, midwife, they need to keep their hand holding that head off the cord the entire time until the baby is taken out via a C-section. So we call that riding the bed, if you will. So they have to actually get on the bed with the patient, keep their hand on that fetal head to keep it from descending back down on the cord, and go to the cesarean section room and get this baby delivered as soon as possible. And they really can't remove their hand until that baby is lifted out of the uterus via the cesarean section. Another way would be this knee chest presentation, but oftentimes because it's such an emergency, the earlier method of just taking the head and pushing it up is a much quicker way to do it. And we also want to make sure we're giving mom oxygen, 10 liters via face mask, because extra oxygenation is going to be required to get to the fetus because they're getting compressed, and limited oxygenation due to the compression of the cord. So we want to make sure that mom is receiving oxygen as well. Another complication is called a compound presentation. This is when the fetal presentation in which the extremity presents alongside the part of the fetus closest to the birth canal. The majority of compound presentations consist of a fetal hand or an arm that presents with a vertex presentation. So this can be reduced, or at least they can try to reduce it by the doctor, but oftentimes it may require a cesarean section because we want to avoid any kind of nerve damage to the fetus or perineal damage to the mom. So this is just a picture of what a compound presentation would look like. So it's a fetal head with an arm or a hand next to it trying to come out at the same time. So obviously if that arm is hyperextended, we're talking about nerve damage, and if this arm is trying to come out at the same time as the head, you definitely can see where perineal damage can occur due to the stretching and tearing. Another high-risk delivery complication can be something called a vasa previa. This is when fetal vessels that are unsupported by the placenta or the umbilical cord traverses the membranes over the cervix. So death can occur to mom and baby. So this is serious. It's not very common, so that's thankfully, but it is a complication that can occur. So notice that the vessels that are connected from mom to baby, the placenta of the baby, they're not protected by either the cord or the placenta like they should be. And this can cause hemorrhaging as well as damage to oxygenation for the baby. And so that would require a cesarean section immediately as well. And we would see that with fetal distress. Another complication is a uterine rupture. This is a partial or complete tear into the uterine muscle. Oftentimes it's associated with a previous uterine scar. If a mom is a grand multipara, if she has been using Pitocin for a long induction or a long period of time, or blunt abdominal trauma. So the signs and symptoms of a uterine rupture can either be nothing at all. Sometimes it can be hidden, or it can be severe abdominal pain. It could be shock because of the loss of blood, chest pain that's between the mother's scapula. Her contractions will abruptly stop. That's a telltale sign on the monitor that a uterine rupture has occurred, because contractions go from happening all the time, or at least, rhythmically and systematically, and all of a sudden they stop. There could be an abnormal or absent fetal heart tone, and if you palpate, you can feel fetal parts outside of the uterus as they have come out of the ruptured uterus. So treatment would obviously be surgery to deliver the fetus immediately, and then to repair the uterus or to remove it altogether with a hysterectomy. Another complication is an amniotic fluid embolism. This is a rare but life-threatening condition when amniotic fluid enters the maternal circulation, and this triggers a serious reaction. So this can sometimes occur through a small rupture blood vessel in the cervix or the uterus, and that is the passageway for the amniotic fluid to get into mom's circulation. It can occur with ruptured or intact membranes, so it doesn't matter whether her water's broken or not. And research suggests that it acts more like an anaphylaxis reaction than it does an actual embolism. So it originally got its name, amniotic fluid embolism, because they thought once it went into the circulatory system, it acted similar to like a pulmonary embolism. But now as research has taken on more evidence, it shows that the body undergoes almost an exact reaction that it would undergo due to an anaphylaxis reaction. So let's say a patient who was allergic to penicillin or a bee sting and had that anaphylactic reaction. So they believe it is more of like an allergic reaction that the circulatory system of mom undergoes when amniotic fluid is mixed to it. So amniotic fluid embolisms can result in cardiorespiratory collapse, and then again also into massive bleeding, or DIC, which we talked about before. It is sudden and severe respiratory distress, and hypotension is seen in mom with the amniotic fluid embolism. And treatments are your ABCs, airway, resuscitation, whatever needs to be done, intubating her, possibly putting her on a ventilator. IV fluids, we need to treat the DIC, or the excessive bleeding, by replacing blood products. Death or severe morbidities are very common from this because of the respiratory insult or the DIC that was suffered. And oftentimes, I would say more than not, moms need an ICU admission because of the severe damage to a lot of her different body systems and organs. A cesarean birth is also considered high risk. So it's not the natural, normal way, right, to have a baby. So surgical delivery of the baby, which is performed through incisions through the abdomen and the uterus. Reasons why we would need to do a cesarean section: if mom was having an abnormal or dysfunctional labor. If there was something called CPD, which is cephalopelvic disproportion, meaning that the head is non-proportionate to the pelvis that it needs to deliver through, either because the head is big in a macrosomic baby, or the pelvis is small or has a mal shape to it, not allowing the head to fit through. Maternal conditions like hypertension, diabetes mellitus, infections can be a reason. If you've had a prior uterine surgery, including a classical or a vertical incision, it is the only option with a previous classical incision. Meaning that, and I'm going to go over this in the next slide, you can cut the uterus one of two ways, and I'll talk to you about it. But anytime the uterus is cut, it has a propensity to tear open, right, wherever that cut was. There's a propensity to dehiss, if you will. So anytime someone's had prior uterine surgery, and it doesn't necessarily have to be a C-section, it could be any surgery on the uterus, maybe to remove fibroids or whatever needed to be done, they have the propensity of having a dehissed incision, so they are at higher risk. So a lot of women who've had previous C-sections will just opt to have a repeat scheduled cesarean delivery because of that increased risk. However, if their previous C-section surgery included what we call a classical or vertical incision, they don't have an option. They have to have another C-section. They cannot labor with a classical previous incision. And I'll go over that here in a moment. Any kind of fetal malpresentations, again, like that footling breech or that transverse lie or oblique lie where the baby is not coming down properly in the birth canal, or a compound presentation, that would be a reason for a C-section. If there's fetal compromise, anytime we notice that the baby is compromised for whatever reason and distressed, that is the quickest way to get the baby out. A placenta previa or abruption can lead to a reason for a cesarean section, and certain pelvic conditions like a previous pelvic fracture or an immobile coccyx. Remember that coccyx has to be able to move a little bit to make way for that infant, and some women who have an immobile coccyx, it just doesn't give that leeway and they can't deliver vaginally. So there are skin incisions to a C-section and there are uterine incisions. So obviously the physician has to cut through the skin first and then the uterus. If the skin incision is done horizontally, that is called a low transverse cut, or often referred to as the bikini cut, as it's right along the level of where a bikini would hit a woman in her abdomen. This is usually done with scheduled C-sections. It's the most common cut that we do. And there really is, I would say, high 90s that we do all these cuts, 90%. A midline or a vertical cut will only really be used in cases where a low transverse is not recommended. And one of those reasons would be maternal obesity. If a mother is very large, morbidly obese, and has a very large hanging pannus, where that cut has to be, it's underneath that pannus. So obviously without the air exposure, there's higher risk of that incision not healing properly and causing infection. So oftentimes they'll cut the skin vertically to avoid that issue and allow for better incision healing. Once they cut through the skin, they are now going to get to the uterus. The uterus can be cut in two different ways. A low segment is a horizontal cut on the uterus. Again, the most common cut. So the low transverse on the skin and the low segment on the uterus are your most common C-section cuts. And then the other kind of cut on the uterus is the classical or the vertical incision. This is only done in cases of extreme emergency where we have really sheer minutes to get the baby out. So this is an example then. So this is the different skin incisions, the horizontal or the low transverse, and then the vertical one here, the midline. And then in the uterus, once the skin is flapped open, again, you can cut the low segment, which is down here, or the classical, which is up and down. When the C-section is being done, the physician will choose how to close the incision by either using sutures, steri-strips, staples, or Dermabond. Oftentimes it is physician preference, but I would say that nowadays you find steri-strips and Dermabond the most common closures. Staples was once used pretty much with everyone, probably let's say 20 to 40 years ago. However, because they don't make the incision look as nice as a Dermabond or a steri-strip, they've kind of abandoned that. And also a patient has to come back to the doctor's office days after she's delivered to get the staples removed. So I would say we don't use those very often. However, we do still use them on that morbidly obese patient we just talked about, as it's a better closure for a heavy weighted pannus that requires a little extra closing help, if you will. So there's usually not a surgical drain placed. However, if one is going to be placed for wound healing, that would be a Jackson Pratt. And again, you would see that oftentimes with that morbidly obese patient. Risk of a cesarean section for mom, there's risk anytime she's needing anesthesia, especially if it's a general anesthetic. Risk of hemorrhaging, blood clots, injury to her urinary tract as well as her bladder, and delayed intestinal peristalsis, or what we call paralytic ileus. In the newborn, they have risks of respiratory problems because of the delayed absorption of lung fluid, injuries such as a laceration or bruising to the infant, and then again that lack of the thoracic squeeze, which can cause some respiratory issues as well. So nursing interventions during a cesarean section is always to support the mother, allow the partner to participate if they can. If it were an emergency cesarean section, especially one requiring general anesthetic, the partner is not allowed to come back. But if they are, they can hold her hand. We can keep her informed during the procedure. We can allow the mother to hold the infant right away, skin to skin if possible. Afterwards, we want to make sure that we're palpating that fundus and assessing her bleeding. We're doing frequent vital signs. We're keeping track of her IV status. We're looking at the dressing status if there's not excessive bleeding on the dressing. We want to make sure we're keeping track of her urine status. Not only is she producing urine, but if there's blood in the urine. Blood in the urine obviously can indicate that the bladder may have been nicked or the urinary tract may have been nicked accidentally by the scalpel during the C-section process. We want to make sure that we're managing her pain. This is major abdominal surgery, remember, so our moms are in a lot of pain. We want to assist with ambulation as soon as possible to prevent things like pulmonary embolisms, DVTs, and pneumonia. We want to offer and instruct her on how to use an incentive spirometer, and we want to instruct her as well on splinting her incision when she is coughing or trying to ambulate. When we talk about a patient who's had a previous section, we talked about how they may choose to have a repeat C-section. However, some patients choose to try to deliver vaginally after they've had a C-section. We call this a TOLAC, or a trial of labor after cesarean. Once somebody has successfully done this, they are now considered a VBAC, or someone who has had a vaginal birth after cesarean. We know that if the patient chooses this, it does put that patient at a higher risk for uterine rupture. There is a risk of previous surgical incisions that dehisce. They have to sign a consent that they understand this risk when they trial the labor. And the physician needs to discuss this in the office prior to them coming into delivery, because they really need to understand and weigh the risk versus benefits. Inductions are higher risk and sometimes contraindicated in someone who's had a previous uterine incision. And again, never allowed with the patient who had the classical uterine incision. And that's the end of our high risk lecture.